Bladder incontinence is a tremendous problem for women. As a matter of fact, 2 out of every 5 women under the age of 60 and 3 out of every 5 women over the age of 60 experience a problem with bladder leakage or dropped organs known as prolapse of the uterus, bladder, vagina, rectum, and are quite symptomatic. The issues which cause incontinence and prolapse include menopause. When you lose your estrogen, the tissues which use the estrogen for support, that's nerve, muscle, and connective tissue, become less strong and less able to contract with a pelvic floor muscle contraction, otherwise known as a Kegel contraction. So you lose your estrogen, and that leads to sagging organs, which frequently lead to incontinence, either stress incontinence or urge incontinence. Stress obviously is leakage with cough, laugh, or sneezing, and urge is that running to the bathroom, that gotta go feeling. So menopause can cause that. Also obesity. We know that increased body mass index leads to increased incontinence. As a matter of fact, loss of only 5 to 10% of your body weight, ideal body weight, or your current body weight, can reduce your incontinence by as much as 30 to 40%. So menopause can cause it, obesity, chronic coughing from smoking or just having a chronic cough from asthma, for example. Childbirth. The more children you have in general, the weaker your muscles, connective tissue, and nerves become. So all of those factors may lead to incontinence. Additionally, there are over 200 medications which may cause incontinence or make it worse. Women may delay treatment. The average is as much as 7 years before they see us for their bladder problems, including incontinence and/or dropped organs. They may delay treatment because of embarrassment, because it is a very embarrassing subject to talk about, and I like to say it's time for incontinence to come out of the water closet. And finally it is. So because of embarrassment, also people may think that it's normal. If you talk to your friend, they may say, oh, I have that, it's normal. So people may think it's not even a problem. Also, women tend to be afraid that if they mention this to their physician, they may hear that the only treatment for this is surgery, when in fact there are many, many other treatments available for incontinence that some involve surgery, but many, many treatments do not. We have seen so many advances in the treatment of pelvic organ prolapse and incontinence over the last 20 to 25 years that it would take hours to go through them. There are that many advances. But a couple of them are the surgeries have gotten a lot better. We now do what's called pelvic floor reconstructive surgery. First of all, we want women to have their pelvic floor in as good shape as possible before they have surgery. In other words, maximizing your pelvic floor strength through physical therapy, through exercise, making those muscles really strong, quieting any unstable contractions, detrusor contractions before a surgery is done, optimizing body weight, minimizing coughing, possibly for some people using some estrogen. It depends on the individual patient. In other words, maximizing your pelvic floor strength and then getting a good diagnosis, finding out exactly what the problem is, where is the weakness, and then correcting that in a site-specific manner. The surgeries have gotten much, much better. We used to just do the surgeries. The urologists would operate on the front part of the pelvis and lift the bladder. The colorectal surgeons would lift the back part by the rectum, and the gynecologists would do the hysterectomy. These days, we're working together to make sure that people have their surgery done at one sitting and every defect, which is kind of like a hernia, is corrected at one sitting. The materials that we're using for pelvic floor reconstructive surgery are getting much better. The medications have gotten much better. We're learning that a lot of medications which cause incontinence don't have to be used. There are other substitutes. And we're learning so many other things about the field of pelvic floor medicine that it is quite an exciting development and very exciting times to be practicing in. The success rates of the surgeries are much better because we're operating on people in a very specific, site-specific manner. We're making sure that people are in the best possible shape before their surgery. optimizing their body weight, minimizing coughing, making sure they don't have a lot of unstable contractions, making sure the bladder is nice and calm, the pelvic floor is nice and strong. So we're having much more success with surgery, and we're choosing our patients who we operate on and the timing much better. We're doing a much better job of educating our patients regarding when they should have their surgery and making sure that it's synchronous with their lifestyle and their healthcare goals for themselves. You know, the recovery time for surgery really varies depending upon what surgery was done, how many sites were addressed, if it's the cystocele or the anterior drop of the bladder, vaginal prolapse, uterine prolapse, or rectal prolapse. The times for recovery for the surgeries are also very variable based on if the surgery was done vaginally, abdominally, laparoscopically, robotically, or a combination of some or all of the above. The recovery times can vary between a week or two up to about 6 to 12 weeks. The one thing we tell patients after surgery, pelvic floor reconstructive surgery, very, very important, is to make sure that they, believe it or not, minimize their lifting and their vacuuming. Because vacuuming, you wouldn't think of it, but vacuuming, the motion of vacuuming can shear the connective tissue and the surgical site repair. So we tell people, I tell them, let your partner or your husband do the vacuuming and the cleaning, the shopping, the lifting. The longer that you allow that pelvic floor surgical site area to heal, the better off you'll be. As a matter of fact, I tell my patients to try to not have intercourse for 6 to 12 weeks also, for obvious reasons. It's like Jell-O. You want to let the Jell-O set. You want to let the repair really, really set. Get your body used to that, having the bladder higher, the colon rectum higher position, and the uterus, the vagina, in a more elevated position. The body has to get used to it.